Fogla nice demonstration of DELC. He is the master of DELC in India. So I will now call upon Professor J.S. TITIYAL. He will be talking on therapeutic keratoplasty in microbial keratitis.
Thank you, Dr. Basar, and I'd like to thank Dr. Namrata Sharma for inviting me for this very successful course for the last so many years. People come and attend. This shows that we do require initiation into a look into a keratitis in our country and the treatment-wise also. We've gone through the entire gamut of different facets of infection in the eye, especially cornea, and their treatment. But you know that almost every patient may not heal with your medical management. There are certain group of patients who requires a therapeutic keratoplasty, and Dr. Rajesh Fogla did talk about cases where you can do a lamellar keratoplasty also. If you look into literature, around 12 to 70% of cases are very difficult to manage and may require a keratoplasty as such. So what are those indications where we might think of a therapeutic keratoplasty? What are the decision-making points by which we decide when to do surgery in these cases? Is there any change in the surgical technique of these cases? And most importantly, what would be the post-op management of these cases who had such a terrifying infection in the normal cornea? And what would happen after you transplant the donor cornea in these cases of such a severity of infection in these cases? There are bound to be complications also. So these are infections which we have seen in previous speakers' list. They would require a therapeutic keratoplasty as such. Just to look into the percentage of cases requiring therapeutic keratoplasty in one institution, this is RP Center. In our center, almost 45% of cases are amongst the all keratoplasty are therapeutic keratoplasty. That shows the importance of a therapeutic keratoplasty requirement in a referral institute like ours, where we get a lot of patients referred with the infection which are end stage and they require a keratoplasty. Which are those cases where you have more chance of therapeutic keratoplasty being done? If you see here, almost 50% of cases are either bacterial or fungal cases in our group of cases. Very small number would be others like acanthamoeba and culture negative patients. But if you look into other area, which is around 34%, is cases where you could not get any culture in the treatment-wise. So I consider these are a patient would be difficult to manage medically, may require a subsequent keratoplasty in these cases. I think Professor Nepalia asked about when should we do therapeutic keratoplasty, and timing is very important consideration for getting a very successful outcome of these therapeutic keratoplasty in our patients. Documentation has to be absolutely perfect, not only for therapeutic keratoplasty, any sort of keratoplasty or any surgery where we remove the tissue from the human body. The documentation should be absolutely perfect with counseling of these patients. Always use good donor tissue. Better the donor tissue, outcome will be better, but sometimes we have to use non-optical grade tissue also in these cases. Technique-wise, it's very simple. We like to save the eye, the integrity of globe, remove the entire infectious load, and keep the normal healthy corneal tissue of a patient and replace with the healthy tissue. Send the button for a culture sensitivity to get an actual organism if possible. Therefore, I think this last line, the timing of surgery is very crucial to achieve good success. And the surgery-wise, not different than any surgery you do in terms of full thickness keratoplasty. Unfortunately, most of the time, these surgeries are done in an emergency time, and maybe the younger corneal surgeon might be doing these surgeries, and they would tell us that how difficult it is as compared to normal optical tissue, because cornea is hazy, sometimes there's a perforation, hypotony, trephination becomes very difficult. So you have to do a gentle trephination without risking the expulsion of intraocular tissues. You may have to do a manual dissection sometimes. Always prepare your donor tissues after the management of host tissue in these cases. A lot of inflammatory membranes will be there that may require a proper dissection without damaging the underlying iris and lens in these cases. Bleeding may be there. Sometimes we have used heparinized solutions to decrease the cobweb formation of inflammatory membranes. Peripheral iridectomy is necessity in all therapeutic grafts. Maybe if not one, you may have to do 2 peripheral iridectomies in these cases to prevent the pupillary block happening in a post-op period. Interrupted sutures should be put, if possible, 10 nylon sutures, and don't hesitate in putting more suture in these cases. Titration of sutures strength also is difficult because the host may be edematous. Similarly, the graft may also be edematous in these cases. So you may require to handle a suture adjustment in the post-op period quite regularly in these cases. And sometimes the sutures are one indicator telling that what is going to happen in the post-op period. Suppose this is a patient who is undergoing keratoplasty. You have to mark the area of infiltration, then go at least 1 millimeter beyond this to have a normal cornea so that you don't have a recurrence coming up these patients. Divide the tissue into multiple parts. Always get a histopad done and culture sensitivity. If needed, you can do a special cultures and specimen can be sent for other higher investigations also. This is what you see in a post-op period. Timing is very important. This is one of our patients at 16 months also. This looks like an optical graft. So if you see this is the periphery is not involved, non-healing ulcer, and the outcome is quite good if you use the optical tissue in these cases. So this is a larger infection. You delayed, the graft quality may be poor, may not achieve the good results in long term. But you have achieved the saving the eye from infection in these cases. So you can do a subsequent optical graft or DSEC in these patients. So this is one of the patients you would have chronic epithelial defect sometimes, which will go into PED and difficult management. In all infection cases, your graft is larger, periphery is always vascularized, edematous. Epithelial healing may be a problem that should be safeguarded every time. This patient is definitely going to have a very poor outcome. See the large ulcer, and this is what happens. This is a small ulcer, non-healing, do early surgery, you achieve a good graft. So all these photographs which I have presented here is to show that the timing is very, very critical and the assessment of patient has to be done appropriately. Yes, it all will depend the pathology behind also, and that might be the cause for recurrence happening in these cases. You all know larger graft, fungal ulcers, especially cases where you could not have the diagnosis proper will have more chances of recurrence happening. If you look into this, I talked about PED, suture-related problems is very, very critical in our country. Otherwise, sometimes we don't really look into systemic and local factors. As Dr. Tully talked about, there are so many other causes for perforation, peripheral thinning happening, which may subsequently cause secondary infection in these patients. Post-op management is very, very important in these patients. Systemic antimicrobials should be used for all cases, bacterial or fungal, for an appropriate time, before surgery and after surgery. Fungal maybe for another 2 to 4 weeks, depending on how patient behaves. Viral keratitis, yes, you have to give for a long, long time, sometimes for 12 months also. But looking at topical antimicrobials, we all will be very happy to use for bacterial cases. Fungal keratitis, again, continue for long term. And viral keratitis, it doesn't normally help giving a topical medications, and same holds true for acanthamoeba also. So this is very critical to supplement the systemic and topical medication by these patients. What about topical corticosteroids? I think that is a critical question we every time get from the audience. When should we start steroid in these cases? Bacterial keratitis, you can start very early. If you have a diagnosis in your hand, you have a bacteria sensitivity in your hand. Fungal keratitis, most people will wait till the epithelialization happen, then see how the patient behaves. Maybe 2 weeks is the early time to start steroid in these patients. And similarly for viral keratitis, you can always give steroids safely in these cases. Acanthamoeba, you have to be a little careful, especially if the patient behaves well. But if patient has a significant inflammation, you may have to start steroid early in these cases, except for fungal corneal ulcers. Cycloplegics, tear substitute, anti-glaucoma is compulsory for all these patients. Anti-glaucoma is much more needed because sometimes the pressure may be very difficult to control after therapeutic grafts because of inflammation going on, peripheral antisynechia, pupillary block. You can have all sorts of glaucoma happening in these patients. You may require a IB mannitol, you require all sorts of topical medications also. Success-wise, most cases do very well. If you have a bacterial, success is almost 100%. Same for viral. Fungal, yes, slightly less in all these cases. Infection in a lamellar grafts like a DSEC, DMEC is difficult to treat. Same holds true for post-refractive surgery infections. So this is one of our cases. We started with just a ICK type picture. We did a DALK, seemed to do well, but after 4 weeks, patient developed recurrence. Ultimately, we had to do a therapeutic full thickness graft in this case. Patch graft is covered by Dr. Rajesh. Little bit on a cross-linked corneal tissue. I think the first time we reported that you can cross-link the donor tissue and put in a fungal corneal ulcers. And it seems to do quite well in terms of prolongability of clarity of these grafts and less chances of recurrence and less chances of wound-related problems. And in the recent times, Dr. Radhika has working on this area for a cross-linking the entire eye so that the host graft junction also gets cross-linked in these cases. That might do better in the future also. And to summarize, the therapeutic keratoplasty is a part of management of infectious keratitis. Significant number of patients may require these surgical interventions. It may be just a patch graft, it may be a glue, it may be lamellar, it may be full thickness, but that will save the day for a patient because you can save the eye, you can do a future rehabilitation with these patients. If you have a bacterial, you have a better outcome. If you have fungal, yes, definitely less chances. But don't forget, after surgery, the management would start subsequently, which may be more difficult than the pre-surgery management for these patients. I would acknowledge the National Eye Bank and my team for helping this poor patient getting through this difficult time. Thank you for your kind attention.
Thank you so much, sir, for that overview on therapeutic keratoplasty. We have 3 minutes, so if there are any questions. Yes?
3 minutes.
Question is for Ogla, how do you prepare that fuller disc to
It's a dermatologic punch to punch out. Use a 2 millimeter punch or a 3 millimeter punch and just punch out any sterile drape or any sterile plastic material that comes in your surgical tray.
and that does not, so the glue will stay on it and then put
You
it on.
can peel the glue off from that. The glue doesn't stick to it.
Thank you.
My question is regarding the fungal keratitis. There has been innovative use by the steroids by the kayaks and over the counter that worsens the condition of the ulcer.
Correct. Off-the-counter use of patients, especially steroid combination, which is so commonly used in our country, and yes, that can really cause difficult fungal infections and difficult to manage. And most importantly, there is a rapid progression of disease. Unlike the classical fungal ulcer, which is slow, progressive, here with the steroid on, they can progress like a pseudomonas ulcer. So sometimes the younger generation might mistake it as a bacterial, but it can be a fungal infection. And you rightly pointed out the outcome in these cases is also difficult.
Yes, so one more, in addition to the vegetative trauma, we have the animal trauma like the cow tail injury which can cause the fungal keratitis.
Sure. Any sort of vegetative trauma or any trauma in the eye can cause any type of infections. Yes, more often it may be a fungal corneal ulcer, especially if you're working in a agriculture field area, trauma in working areas. They always predisposed to these ulcers, and fungal ulcer is the commonest one.
And the other comment about worsening after 2 days of instituting treatment, one of the reasons can be that the patient was using steroids earlier, and when he came to you, you diagnosed it as a fungal keratitis, discontinued the steroids and instituted antifungal, and then they start feeling that the eye symptoms have got worse because previously the steroids were suppressing these symptoms.
Yeah, absolutely true.